All right, second to last page over here is the Reeval MDM page. And this is where all your reevaluations, multiple visits to the patient would be documented, all the consultations to physicians, and differential diagnosis would be documented. So a lot of things on this page, and really only a handful of them will really be documented on them for the most part, and you can go through the rest of them if you'd like to document more things like the stable or patient safe to go home or any of those. The first thing I want to point out is under this additional history information from tab is going to have your prior records reviewed button. So if you do review prior labs, EKGs, or any other prior records or inpatient records, then you could check this and then go into the comments here or type in extra comments if you're getting into detail on what happened with the patient previously. If you get some additional history from the family or anybody else later on, you can also document all that in this section.
Now, Dr. Goldman, can you comment on additional history that on HPI versus additional history on this? Like if on HPI we say, the wife brings him in because she thinks he's having a stroke, versus getting more history from the wife here saying that, you pull her aside and, he took a bunch of pills before coming in. What's that in terms of kind of points and complexity of your chart?
Yeah, I think, ideally, in either area that information should be captured. I will say, though, that in this area, as it's actually kind of specifically laid out for this, it's much easier for our current billing company to find that information in this location. So my recommendations would be, if possible, to put that information in here, both the prior records reviewed or history from family members or paramedics and stuff like that. And then I would definitely recommend using instead of the comment box, because again, it's limited in terms of space, using the dotted line to say, you could say, patient was seen 2 days ago, had a cardiac cath, was negative, or patient discharged a month ago, history of pneumonia, those kind of things. And again, this is really good stuff. One, from a billing perspective, it can add data. Two, from medical management, we're very much looking at getting away from superfluous tests, extra CTs, X-rays. And if you can document here, this patient was seen 2 days ago, had an X-ray done, and now that's your decision making to review that instead of ordering another one, is something that's definitely being followed and will continue to be followed moving forward. But Dr. Brokish, to answer your question, I think this would be the best area to click on the area, especially regarding old records reviewed and summarized and additional history from other outside sources, EMS, family members, etc.
Okay. All right. The next line we have over here is a reevaluation line. So this is meant for a reevaluation or a re-exam, and you can just put in the time or document any of these as applicable. And for the most part, people have been just documenting everything in the additional notes, saying patient reevaluated, feels better after Toradol, will discharge home, and follow up with whatever. So just a quick couple of lines here, and the time is pretty much what everyone's doing for the most part, and you can put in some more details here.
And I'll add on to that. This is, again, from my perspective, again, more from a medical legal standpoint, this is a wonderful area, especially on some of your more complex patients, to either have multiple notes. You can obviously use the repeat button to do that. But, somebody who's an asthmatic who's having multiple reassessments secondary to their status, they got 3 nebs. How are they doing now? Oh, they're doing better. We're giving 1 more neb. Oh, now they're doing better. Your allergic reactions, your sicker patients. Again, this is a specific area that really is one of the only ones in EMRs to make your chart look very, very unique. That you thought about this and now you're reevaluating and now your things have changed a little bit. So I would recommend using this box as many times as possible. Now for your simple ankle sprains, probably not something that you need to do. The other thing that this might happen is, if you're working with a mid-level, say you don't have a scribe, you might not go through and put all the rest of the history and physical, but you might just document in this box that, I saw and evaluated the patient. This was the initial finding. We got all the blood work. It was all negative. And now the patient's ready to go home, and you can put pretty much all of your information in one single area on the chart instead of having to click through multiple areas to get that information.
All right. The next line we have over here that we're going to talk about is the consultations page. So consultations is where you document any phone calls or consults to other physicians. The first line over here is the referral consultant's name. So you just start typing in the consultant's last name and find whoever that is, select them, and select their specialty in this second line, and call requested time. If you're doing this live, you can click that now and today, and call return time. Put in whatever time they return the call. And then under consultants, you'll have the options of saying what the consultant will do if they're seeing the patient, or they agree with your evaluation, agree with plan, or anything else. You can also go into detail over here just to summarize your conversation with them. If this is the hospitalist in this case that is accepting the admission for the patient, then you can click on the admit accepts yes button over here. So this admit accepts yes button, along with the time of the call return time, will change the tracker to the DISA for disposition for admission. So this is what will flag the tracker to be to show admissions and to flag the nurses and everybody else that this patient is ready for admission. There are a couple of different ways, or this is the way to do it for admission, and there are different ways to do it for disposition home and disposition for transfer, but this is the way for admission, and the other two are in the dispo page that we'll get into.
So I just want to verify that too, because obviously we're all very aware of our metrics, and also we want to start being able to calculate our length of stay in the ED after the patient has been dispoed. So for admitted patients, the two elements that I guess for sure have to be there to stop the clock from our time in the ED being done is technically the call returned. Do you need the time also returned, and admit accepts with a yes? Is that correct?
Yeah.
So those three, obviously you're going to have the name of the consultant. It's always good to say what time you called and what time you actually got the return call, again, for tracking purposes. But those three elements have to be there to stop the clock on the dashboards that we're all following.
Correct.
The one thing that I've noticed in terms of for the consultations is that the admitting physician needs to be the first consultation. So like, let's say for example, you talk to orthopedics and orthopedic surgeon says, it's a 40-year-old male that broke his form, whatever, and but he has a history of hypertension or something like that. If the orthopedic doctor was the first consultant, but it said admit to medicine, and the hospitalist was the consultant number 2, and you say accepts admit, it actually will not flag it on the tracker. So basically, what I've been doing, or again, I don't know if this is the best way to do it. Let's just say, for example, this consultant number 1, just to switch things around a little bit, is not the hospitalist, and let's say it's the orthopedic guy. And basically, what I'll do is I'll go down here and I'll say, admits accepts, yes, but then I'll just say, but admit to hospitalists, and then because otherwise, if you don't click this yes under the consultation 1. It does not flag it on it, and so then the nurse says, "Are you going to admit this patient, or is this patient going home?" Because if you just say that, if you just leave this blank, for example, we'll see patient, requests hospitalist, and you go up to here and you put in all the different components that Nasser just put in, hospitalist, and even if you scroll all the way down and you put yes here, it will not flag it on the tracker. It will not flag it on the tracker. So again, what I've been doing, and again, if you guys have a better suggestion, I just put that yes, the orthopedic accepts the admission, but that admit primarily to hospitalists or something like that.
So I guess the two options would be, no matter what, consultation 1 has to have the admit accepts yes to stop all things. So your two choices would be, as Dr. Brokish said, to do it that way, where you say yes and then add a caveat in the comment section, or your other choice would be, obviously, to always put the admitting person, the true admitting person first, like the hospitalist first and the ortho second, even if that's not necessarily the order you called them in. So either way will work, but we just need to make sure that consultation number 1 has the admit accepts box checked.
Exactly.
All right. And last couple of lines to go over on this page. So you have the non-provider consultant. So this won't have a field to search for the physicians. This is if you talk to the Green Oaks counselor or somebody that's not a physician and you just want to type in a quick note on what they say, that could be in here, or a nurse from another facility or something. So differential diagnosis over here, this is more pertinent to our current chart. So these are all the differentials you can select and comment underneath for our chest pain template. A few other buttons over here that you can document if you'd like to document some more details under clicks, but for the most part you would have already addressed those in the reevaluation or any of those text boxes.
I'll just add in one last thing, or a couple last things here. One, obviously the differential diagnosis is always a good idea. This just really kind of goes through your thought process. It's definitely not 100% needed. People have talked about, differential diagnosis at the end in your medical decision making in terms of I thought about this, I thought about that. In your differential, that's what this is suggesting, that these are the things that you thought about. So again, from more of a medical legal standpoint, that's always a good thing to think about. The last part I'll say here is in considerations. I've seen this done a lot, and if this goes again between the difference between billing and from a medical legal standpoint, lots of times we want to paint our picture of a patient not being very sick, and that's why we let them go home or for whatever various reasons. But I have seen, and just to make you aware, again, we get a little bit click happy sometimes, somebody who is on a cardine drip, going to the ICU, you bill critical care time for, all great, and then you put severity, non-life threatening. Well, that becomes a little bit of a problem when the auditor looks at it and says, well, you're trying to say this person is critical, and now you're saying their severity is not life-threatening, which is, actually a needed component of being critical care. So just be careful, again, that you're not contradicting yourself within the chart by just clicking an extra box just to click an extra box. If it's pertinent, then definitely do it, but just make sure that that's going to come across and you don't want to contradict yourself later in your chart.